Good afternoon. I know you've had a full day of great presentations about nutritional needs and the feeding needs of children with neurological impairment. Thank you for the opportunity to discuss the anthropometric measurements in children with cerebral palsy. I'm the dietitian that's part of a multidisciplinary team that cares for children with special needs. The children in our program have cerebral palsy, chromosome abnormalities, Down syndrome, spina bifida, and muscle disease. One of the roles of the dietitian in our clinic is to obtain the measurements on the children that are unable to stand. We also obtain some body composition measurements, such as skin fold measurements and mid-upper arm measurements. Today, I'll discuss the anthropometrics used in the nutritional assessment of children with cerebral palsy. I will describe the alternate height measures for non-ambulatory children with cerebral palsy, and we will review body composition techniques such as mid-upper arm circumference, as well as skin fold measurements. When we think about children with cerebral palsy, we know that nutrition problems are common, and Dr. Sullivan spoke about many of those problems in his earlier lecture. Malnutrition, poor linear growth, and stunting, which may be nutritional or endocrine or related to the cerebral palsy itself, is not uncommon. Many of the children can also have problems with being overweight. Micronutrient deficiencies can be seen, as well as problems with bone density. That makes nutrition assessment imperative in this population. When we look at the domains of nutrition assessment, we can see that anthropometrics are one of the most important domains, as well as nutrition-focused physical exam. And I personally think that those two domains work closely together. And we'll talk mainly about anthropometrics today, but at the end I am going to touch about the importance of doing a nutrition-focused physical exam in combination with those anthropometrics. There are definitely challenges in obtaining accurate anthropometrics in this population. The children may be unable to stand. They may have joint contractures, which make it impossible to straighten the limbs. They may have muscle weakness, involuntary movements, difficulty with cooperation, which sometimes we see in the pediatric population in general. They may also have scoliosis, spasticity, and they also have differences in their body composition, and that's what makes them so challenging and interesting to care for. But obtaining these anthropometric measurements and them to the best of our ability is very important. In the United States, we obtain head circumference in children less than 2 years of age, and to do that, we place the tape around the frontal bones just above the eyebrows, above the ears, and around the occipital prominence, which is the largest part of the back of the head. We also obtain weights in children and recumbent lengths in children less than 2 and in children who are unable to stand. When children are unable to stand, that is when we consider some of those alternate height measures that we'll discuss today. So recumbent length, again, we would obtain in infants and children less than 2, and we use a length board. We need to remember that recumbent length is not useful if the patient has scoliosis or contracture. So when you look at the patient, it doesn't appear as if they'll be able to bend their knees or they have a significant curvature. This is not a patient that we would use recumbent length in. We want to remove the patient's shoes and socks. And when we're using a length board, we want to ensure that the top of their head is touching the headboard and that their shoulders and buttocks are touching the table and their heels are also touching the table. We want to slide that footboard to the bottom of the subject's feet up against the heel. We use knee height in patients where we're unable to obtain a standing height or a recumbent length if they have those contractures or scoliosis. And for the knee height, we want to be sure we're removing their socks and shoes. You need to use that caliper that you see there in the picture. And you want to measure the longest leg or the least affected leg, because many times the children may have hip problems, and so sometimes I'll even ask is one leg longer than the other, or I'll visually look and see, and I want to be sure that I'm measuring the longest leg. If the patient is up in the chair or if they're lying down, we need that knee to be at a 90-degree angle. We place the blade of the caliper under the heel of the foot, and then you slide the top part up, the black plastic piece, and put that right across the anterior surface of the thigh, just proximal to the kneecap. Then you're going to get a measurement, and that measurement's going to be in centimeters. And you can plug that centimeter measurement into one of these equations, and that'll give you that proxy for their height. And you could then compare that child to the standards that you choose to use as far as growth charts. The next measurement that we'll talk about is tibial length. And with tibial length, you can use a flexible tape measure, so it does not require using calipers. And for tibial length, ideally, you'd like the patient in a seated position. You can do this with them lying down. You want to measure the inside of the leg, and so ideally, you would cross that right leg over the left, right above the knee, and you would measure from the medial joint line of the knee to the distal edge of the medial malleolus. And so that medial joint line is the crease on the inside of the knee, right above the calf, and the distal edge of that medial malleolus is that inside of ankle bone. It's a protrusion on the inside of the ankle. So again, when you get that tibial length in centimeters, you can plug it into one of these equations. That top equation is specific to children with cerebral palsy, and the bottom equation are studies that have been done in typically developing children used to develop tibial length. Arm span is something that I don't use often in children with cerebral palsy, but I have used it in children with spina bifida. And there have been occasions where I've been able to use this measurement, or I've had to use it because the knee height wasn't possible. So the arm span, we would want to be sure that the patient is contracture-free and that they're able to completely stretch their arms out straight. And so we would ask the patient or help the patient. This measurement should be done with some help. And so you're going to need that caregiver to help, or a nurse can help. And we want the patient to have their arms outstretched, and we want to measure from the tip of the middle finger of the right hand to the tip of the middle finger of the left hand. And then we can plug that number into an equation and get an estimate for their height. Mid-upper arm circumference is something that we started doing in our patients a few years ago. And this was a result of a paper that came out from Dr. Mehta that recommended that all children, whether they're typically developed or not, have a mid-upper arm circumference as a measurement of nutritional status. And this is used to screen for malnutrition in poorly resourced countries. And there are a lot of studies showing that it predicts malnutrition-related mortality. The good thing about this measurement is it is not affected by edema. It's simple and accurate. We want to be sure that we're interpreting this measurement, though, in caution with children with cerebral palsy, because they do have decreased muscle mass. I've found this measurement helpful to follow over time. And again, with just the same as with any of our measurements, we do want to follow the trend, and we can compare the child to themselves. The process for obtaining the mid-upper arm circumference is listed here. The first thing that we need to do is mark the midpoint of the arm. And so we would want the patient to be facing away from us. And sometimes I'm doing this with the patient lying down on a mat table, or perhaps they're sitting even on their parent's lap or in their wheelchair, and we would need them to bend forward a little bit so we could get to the back of that arm. So we want the arm bent at a 90-degree angle with the palm facing up, and we want to measure from the acromion process down to the olecranon process, which is the elbow. So that acromion process is going to be that bony protrusion on the back of the shoulder. And so you want to measure from there straight down the back of the arm and then mark that midpoint. For the second step, you want the patient to have their arm relaxed at the side, because if they had it at that right angle, that's going to change your measurement because you're going to get more of that muscle. It could change your measurement by as much as a centimeter. So you want that arm relaxed down at the side, and then you want to wrap the tape measure around the arm at that midpoint, and then you want to record that circumference in the nearest 0.1 centimeters. The next measurement that we do is the tricep skin fold measurement, and this is helpful in estimating body fat. Tricep skin fold less than the 10th percentile can be an indication of undernutrition in children with cerebral palsy. We want to repeat this measurement 2 times within 10% to be sure we have an accurate measurement. We want to follow the trend, again, with this measurement. There are some CP-adjusted equations by Dr. Gurka that correlate with DEXA and body composition, and so those equations would be useful in using a tricep skin fold and a scapular tricep skin fold measurement. So to do a tricep skin fold measurement, we would, again, go to that midpoint that we used for the mid-upper arm circumference measurement. We want to grasp a vertical pinch of skin between the thumb and the forefinger, about a centimeter above that marked midpoint. Place that caliper there at the midpoint, and you want to be sure to keep that skin fold in your finger. So don't let go of that and just let the calipers hold the patient's skin. You want to keep holding that that skin fold while you're doing the measurements. And again, it's really best with your measurements to measure them 3 times and average that measurement. If you're going to do it 2 times, you want to be sure that those numbers are within 10% of each other. The subscapular skin fold is another measurement that can be done to help assess body fat. And you want to locate the patient's scapula, which is the shoulder blade on the patient's back, and locate the inferior border of that scapula. And with this, you want to grasp a horizontal pinch of skin below the right scapula, and then do your skin fold a centimeter above that thumb and finger measurement. And again, average those 3 readings in millimeters. Nutrition-focused physical exam, I think, is very helpful to combine with our anthropometric measurements. And when we do a nutrition-focused physical exam, we can learn a lot about our patients. And so sometimes we can identify malnutrition by looking at the patient and seeing that we can see their ribs that they've had, muscle and fat wasting. And I'm often asked, is this helpful in patients that are non-ambulatory because they're not going to have that muscle mass? But I've seen in patients that are malnourished, you can see, hanging skin and those kind of things that may indicate that the patient has lost weight. So looking at our patients is very important. We also want to have a sense of do they have contractures or scoliosis? All these things are going to be really important when we're deciding which anthropometric measurement to do. We can also use physical exam to see how our patients' abdomens are, and we want to look for skin breakdown and do an oral exam that can help us even identify some micronutrient deficiencies. So I think all of these things are very helpful in combining with our anthropometric measurements to help assess our patients' nutritional status. When we're thinking about things that may be helpful when we're measuring our patients, some of these things may be new if you haven't done them with your patients before. And so I always explain what I'm doing, because sometimes those skin fold calipers can be scary, for the caregivers, especially for the children. And so a lot of times I'll even use the skin fold calipers on the caregiver's arm just to show them that it's not painful. We want to be sure that when we're measuring directly on the skin and not the clothing, and that we're documenting the type of method that we use to measure the patient. So for example, if I use the knee height caliper, I'm going to say I measured the patient's right leg using knee height, or I'll use recumbent length. But I want to be sure that I documented that, so when the patient comes back to see me next time, that I measure them in the same way and that I'm measuring the same side. Again, averaging 3 measurements would increase our accuracy. We want to be sure that we're using clinical judgment when we're deciding which reference range to use. And again, it's very helpful to follow these measurements over time. So children with neurological impairment are at risk for nutritional problems, and their assessment can be very challenging. Learning some of these skills to obtain height and assess body composition will be helpful in the assessment of our patients and can make a difference in the care we provide. I'm looking forward to seeing you in person in the fall, where we can talk more about anthropometrics. But now you have the opportunity to practice some of these measurements with each other. And so we will now close, and you can take that opportunity to learn some of these new skills. Thank you.